I think we can all agree that we are building our clinical edifice upon solid rock foundations of our preclinical platform. And really what my job is over the next half an hour is to convince you that we're not building that edifice out of straw. But before starting, I'd like to emphasize a few key points about RNAi. This follows on really from what Jörg and Ali were telling you a bit earlier on about the central dogma and also the conclusion of the Human Genome Project. And that is that, namely, once you have a drug target in your sight, the siRNA required to silence that can be devised rapidly within hours. The actual siRNA for testing can be developed very quickly, within weeks. And as long as you have suitable and validated delivery systems, it can be dispensed for use in clinical trials within a matter of months. The key to unlocking that potential, of course, lies in delivery, and I think Jörg has very ably explained the importance of delivery to us and to the field. So before I pick up the reins and take the story forward another step, I'd like to take the opportunity of paraphrasing somebody who's been a far better public speaker than myself, and say that what I'm going to talk to you about now is not the end of our story. It's not even the beginning of the end, but to a certain extent it may be the end of our beginning. And when I actually put that in, I kind of wasn't forgetting that for an Anglo-German company, quoting Churchill may be unusual, particularly before the friendly football match. So what actually is the end of our beginning? Well, firstly, what I'd like to do is to share with you some of the fruits of Jörg's team's work in our engine room in Berlin. And I'll move on from that to try and describe how we began to translate this preclinical promise into a clinical reality. And a format that I'm going to follow throughout the presentation, which is moving on from describing the preclinical validation studies and into how we're launching that or taking that forward into the clinic. I'd also like to promise that I'm going to kind of dispense with any more sort of sound bites here. And so if I start saying anything about sea changes, about paradigm shifts or Damascene conversions, feel free to groan. And if you start hearing me going on about the hand of history, you can throw bread rolls. So what I'm going to talk about first is about the process of developing a novel anti-metastatic drug. And I'm going to start by taking you through some of the preclinical evidence that have led to us developing that hypothesis, and then really the clinical trials that we've developed to try and confirm or test that hypothesis. So firstly, for us, the kind of road towards an anti-metastatic drug looks something like this. We have, in this case, ATU-027, which is one of our lead compounds, which is targeting an important protein called PKN3, which I'm going to tell you a little bit about now. Ultimately, we believe from our preclinical data that we have a drug that targets specifically metastatic cancer. I'm going to share with you a little bit about our plans in the clinic to try and prove that hypothesis. So an ongoing trial, which has already been launched in pancreatic cancer, a head and neck cancer trial, which Ali alluded to, that we've agreed to do together with investigators at the University of Birmingham, and maybe talk a little bit more about other intermediate indications along that way. So Jörg has already talked to you a bit about what ATU-027 is, so I'm not going to dwell on that anymore here, but this particular context, we're talking about a system that delivers an siRNA to target this important messenger RNA and the protein that encodes PKN3. Now PKN3 sits on an important branch line of this very important signaling system, the PI3 kinase signaling system. You can see how complicated this system actually is. In general, signaling systems all operate in pretty much the same way, in that you have relaying of messages via these signaling systems from the outside of the cell, or sometimes due to proteins, mutant proteins inside the cell that become damaged in some way. And these systems relay messages down to the kind of shop floor of the cell, where these message relays are translated into some kind of action. In the case of a cancer cell, an undesirable action like cell division, abnormal motility, or the production of a protein you really don't want. And the beauty here is that by targeting proteins in these important relays, you also inhibit or interfere with the abnormal process that lies at the end of that relay. And that's, if you like, really the concept or the underlying notion to all targeted therapeutics, and siRNA or RNA interference in particular. You can see by the complexity of this that it's quite a hard thing to understand, but fortunately some very gifted scientists have developed an A to Z to kind of help you along the way. It's not available in all good bookshops. It should be on the shelf here, actually. So We brought some with me. So what about the kind of first steps in that preclinical journey? What I'm going to do is to kind of retrace some of Jörg and Jörg's team's work here that led us to conclude that 027 is an anti-metastatic drug. So to very briefly skip over some of the beginnings of this story, firstly, Atuplex, which if you like is the vehicle that carries the siRNA cargo to various different places. And as we all know, Germans are good at making vehicles. So this, if you like, is the kind of Mercedes equivalent. And you can see here that, as indicated by this red fluorescent tag that's been stuck on the end of the siRNA, that this is, in this case, delivered to the vascular endothelium, as Jörg told us earlier. And what's more, that with the Atuplex formulation, it's delivered to the endothelium of essentially most major organ systems, maybe with one interesting exception here, which we won't have time to kind of talk about here, but that's the brain, maybe because of the blood-brain barrier. And importantly here, not only does Atuplex carry siRNA into the various different tissue compartments, but as you can see here, it silences the target, in this case PKN3 is indicated here by messenger RNA measurements, in two important scenarios, lung and liver. And I'm kind of focusing on these because for an anti-metastatic drug, affecting the protein, the signaling protein in these two target tissues is clearly important because this is where a lot of metastases happen. Silencing a target gene or protein is all well and good, but the important thing here is that those changes in PKN3 or the silencing in PKN3 also result in important changes in the molecular characteristics of the blood vessels that are being targeted. And in this case, we get changes in this important protein, VE cadherin, which is a cell adhesion molecule. The kind of cell adhesion molecules, if you like, are sort of like cellular rivets. And what they do is they actually join neighbouring cells tightly together. So tightly together that it's kind of hard for things to get between the cells. Things like chemicals and things like cells, which are large, can't get between if these rivets are working. Importantly here, we can link the upregulation of VE cadherin in a single experiment directly with those changes or silencing of PKN3. So as you can see here in this gel on the left-hand side, where PKN3 is silenced, you can see that this protein VE cadherin is increased. And this is from a Western blot, and you can see the same thing here in a micrograph. In addition to molecular changes, there is a clear alteration in the behaviour of blood vessels that can be seen. So here in this model, what we're showing is that in a process of inflammation, there are changes in endothelial cells. And these changes in endothelial cells can be seen here by this alignment of what are called actin fibres. Now these actin fibres are lining up, and it's not hard to imagine from that picture how these fibres, which are able to contract, could pull in the cell, therefore separating it from its neighbours. And of course in inflammation, one of the things that happens is that pores or passages are opened up between neighbouring cells. And in this case you can see that this change can be induced by a classical inflammatory chemical tumour necrosis factor alpha. An interesting thing here is that in the presence of an siRNA to PKN3, this change in the actin fibres is altered or changed. So suggesting that in fact that maybe with PKN3 that this normal pulling apart of cells that happens in inflammation could be prevented. And what you can see in this slide here is that there is indeed a change in the quality of blood vessels due to inhibition of PKN3. And look, a really important thing you can see here is that there's a change in the aggregation or collection of inflammatory cells that's seen here in this control sample that's kind of prevented here in the ATU-027 treated group. So suggesting here that by altering the expression of these cellular rivets, we're actually preventing cells from getting from blood vessels into the tumour, in this case inflammatory cells. Of course, the $1 million question is that if we can stop inflammatory cells getting into tumours, can we stop cancer cells from getting out of them and into the circulation? A very important step in the metastatic process. Well, actually, the easiest way of trying to answer the question about effects on metastases is to move into preclinical models of cancer in which primary tumours are induced and in which metastases happen. And without going through every single tumour model that we've looked at here, but suffice it to say we've looked at quite a lot of them, as you can see here, different ones in the prostate, pancreas, lung, breast, melanoma, line, and also colorectal cancer. What you can see is an almost universal and reproducible change in the total amount of tumour burden in the treated mice predominantly due to an inhibition of the formation and development of metastases. And a lot of this is published, so the details are there, so I'm not going to dwell on that much further. What I would like to do is just to focus on a couple of those individual models and show you some of the results graphically. So in this case, we have a breast cancer model, and mice were, if you like, injected with these tumour cells, and a period of time was allowed for the development of tumours and tumours forming metastases. And what you can see in this scenario is very little effect of A2027 on the primary tumour. But look at this. Up here you can see these brown cells, which are metastatic cancer cells, almost completely prevented at the earlier time points, and only at the very late time points do you get a small number of metastases developing in the treated group. But look at that compared to untreated control mice. And this is pretty much showing the same thing, but in a different breast cancer model. And in this one, we've tried to mimic a scenario that would be present, say, in the treatment or the adjuvant treatment of a human cancer. So in this case, tumours are induced, but the primary tumour is then operated on and removed, and a period of time for observation is allowed, during which secondary tumours or metastases develop. And look here again, in the control group, these brown areas represent metastatic tumours, and here in the O27 treated group, the development of these metastatic tumours is drastically curtailed. You see again here in a control group, without the siRNA, again, there's no effect on metastases formation. So to kind of just round off or recap here, A2027 knocks down PKN3 in the lining of blood vessels. And this results in a change both in the molecular phenotype, in other words, if you like, the molecules that are produced in the lining of the blood vessel, and also in the anatomy of that blood vessel. And importantly, these changes are actually resulting in a change in behaviour, in this case a resistance to the formation of metastatic lesions. Now what we need to do now is to see whether or not this anti-metastatic hypothesis, based on our preclinical studies, is also matched in the clinic. Now what I'd like to explain to you is really to make that link between locking up the endothelium against cancer cells and an anti-metastatic effect. Now the formation of metastases is an extremely complicated area which can involve a number of different processes. But at least two of these processes are amenable to an endothelium-targeted drug like A2027. And these are, one, the intravasation of cancer cells from the tumour into the blood vessels. So the necessary precursor step to metastasis formation is the ability of these cancer cells to get into a highway system in which they can pass around the body and reach tissues like liver, lung, distant to the primary tumour. Another area in which a drug that locks up the endothelium could potentially prevent metastases is by actually preventing the extravasation of cancer cells that have managed to enter the circulation into a site of metastasis formation like the lung or liver. I think it's important to emphasise here that there are, of course, numerous other possible ways in which an endothelium-targeted drug could potentially interfere with cancer and metastases. Some of these are being actively explored in our lab and in our collaborating groups, but let me run through a few possibilities, and these may range from a change in blood flow into the tumour, altering the expression of oxygen-related factors that are important for driving cancer. And there are these various factors called HIFs, or hypoxia-inducible factors, that are now important cancer targets in their own right, ranging from that kind of molecular change to actually just a physical change, that if you alter blood flow through a tumour, you change the pressure in the tumour. There have been a lot of publications recently suggesting that if you can reduce the pressure in the tumour, it's easier to get drugs into them and it may be easier to treat them. So of course it would be naive of us to assume that we know the whole story about PKN3 biology, because this ingress-egress, if you like, intravasation, extravasation story fits with what we know about the molecular changes. The important thing is that whatever our gaps might be about the biology, we know the drug works in metastases models. And we're actively trying to find out whether there are other bits of the story that we need to still learn. So let's kind of conclude by saying that at the moment our best working hypothesis is that A2027 slams the door of the endothelium in the face of cancer cells and stops them getting in and out of blood vessels. And that may at least in part explain the anti-metastatic effect. And I'll apologise for the fact that I seem to have put in a sound bite there. And is that the hand of history hovering over my shoulder? I don't know. So I'm getting close to the end of the beginning, not close enough that any of you can breathe a sigh of relief that we're nearing the end of the presentations, I'm afraid to say. But so look, armed with the knowledge that we've got an anti-metastatic drug in our grasp, I'd like to share with you our progress into the clinic and how we're going to try and prove this working hypothesis of the anti-metastatic action in man. But the first part of that process, and I'm not going to dwell on this because Jörg has already hinted about the complexity of the process of taking a drug from preclinical models into man, but suffice it to say that we've have done this and in non-human primates, and this is just to kind of emphasize that in non-human primates we have demonstration of PKN3 activity at the protein and the messenger RNA level, and we can demonstrate the presence of RNA interference. We also have obviously a full toxic package that was there for preparing our journey into man that I'm not going to dwell on now because this is largely a very standard procedure. So the first of our clinical trials was this one, which is a phase 1, first in human study of ATU-027, and this followed a kind of very standard dose escalation 3+3 design, in which in this case we have 10 different dose levels, and we recruit 3 patients to each dose level, plus an additional 3 at the top dose level, making 6 in total. And the treatment, in order to satisfy what is ultimately largely a safety, proof of safety study, is that we give the first dose, here seem to be, there, we have an observation period of a few weeks in between before we then have a month's worth of twice weekly infusions before we have a second follow-up period. We have scans before treatment and then at 2 months, and then we have a further scan at the end of study at which we can look at some clinical endpoints in addition to the standard measures of toxicity. This is a summary of the results of the concluded phase 1 study, which were actually presented at the ASCO meeting, that's the American Society of Clinical Oncology meeting in Chicago earlier this year, and this is now being prepared for publication and hopefully which will be submitted within the next week or two. I'm not going to go through everything on this busy slide, but what I am going to do in the next 2 slides is just pick a few salient points, both from the efficacy side of things and from the safety side of things, and concentrate on those. So if you look here, the bottom line results are that if you look at all those patients who actually managed to complete treatment, over half had stable disease, partial regression at the week 1 after the last treatment, so on the follow-up scan. That's 14 out of the 27 patients who completed all visits. If you include the 9 patients who didn't make it through to the end of the trial, that includes 3 patients who dropped out at dose level 1 for various reasons unrelated to therapy. But this is the nature of treating patients with very advanced disease. I mean, many of these patients had had up to 5 different types of anti-cancer therapy and had been pretty much told by their clinicians that they'd reached the end of treatment. There was nothing else on offer, but we have this trial drug that if you're willing to give it a go, and that's very much how these advanced cancer studies work. So even if you analyse this by intention to treat and you include all 36 patients, that's a very satisfying around 42% patients who had stable disease or partial regression at week 1 after treatment. If we look at the end of study, which was an additional few weeks beyond that second or first follow-up scan, we had 11 patients who had either partial regression or stable disease at that time point. And another 6 patients actually went on beyond the planned study protocol to have additional treatment on compassionate grounds. To kind of focus on those go signals for an anti-metastatic drug, we had 1 patient who had complete regression of a pulmonary lesion. If you look on this scan here, this pulmonary lesion which was there before treatment has completely gone on the follow-up scan, so that's obviously exciting for us. In addition to that, we had a further 2 patients who had metastases that showed some partial regression in lymph node, liver, and also lung. And we had 4 patients who showed either stable disease or regression of bony metastases. So all these are very exciting for us. Overall, about 10% of patients showed some improvement in performance status as measured by ECOG, which again is exciting. Now, look, I have to say that this is a small study aimed primarily at safety. I can't claim that any of these results are statistically significant, but for us, they provide a very powerful motivation to take this drug forward into further clinical trials in which we can start to actually develop statistical proof eventually of the anti-metastatic effects of this drug. So this is a go signal for progress. The safety and tolerability of ATU-027 provides further justification for us progressing with this drug. ATU-027 was extremely well tolerated. In fact, in terms of serious adverse events, the only significant one noted was one period of anxiety or at dose level 1, which is unlikely, though of course it could be related to the drug. It may be a more patient-related phenomenon. We had one potential dose-limiting toxicity, which was an elevation in lipase at dose level 10. But there were no clinical consequences of this lipase elevation. So lipase is used in Germany, where in the UK we use amylase as a potential marker for a condition called pancreatitis. But we emphasise that we've had no episodes of pancreatitis in this trial or subsequent trials. So we don't know whether lipase is actually a relevant marker here. It's possible that it could be related to the lipid infusion and have no other consequences than that. So it could just be a marker. In terms of minor adverse events, most of these were grade 1 or 2, which is very low-grade toxicity, and the majority one that we found was fatigue. But bearing in mind that these patients had a very lengthy protocol of infusions and PK measurements, and even our investigators thought this was more related to the period of time they had to spend in hospital undergoing the trial rather than the treatment itself. And we also had a few other scattered lipase elevations. I think it's also worth emphasising, particularly as other siRNA preparations have been associated with immune activation, and in some cases have required quite extensive pre-medication to avoid clinical side effects of that immune activation, that although we had some sporadic activation of cytokines and complement, none of this was clinically relevant, and no patients required any form of pre-medication or treatment to deal with that. I'm sure all of you realise that, for anyone developing a new drug, biomarkers to monitor treatment are very important. I think it's particularly important when you develop a drug to a relatively inaccessible tissue like the vascular endothelium. And in this study, we looked at around 100-odd serum proteins using various different ELISA immunoassays. And what we found was that only one of these proteins had a reproducible relationship to treatment, and that was downregulation of soluble VEGF receptor, also known as soluble FLT1. And this is also biologically plausible given the endothelial activity of the drug. So we have a potential biomarker, but again, in the same way as I can't tell you that the efficacy is significant, I can't tell you that this biomarker is significant, but this is also going to be followed up in all of our further trials to see whether this is borne out, but at least it has promise. So just to kind of summarise on this, we can say that our results, both from preclinical through to clinical data, are consistent with an effective anti-metastatic drug. This is a hypothesis, a working hypothesis. We also have some suspicions from the biology as to why it's an anti-metastatic drug, but there's a lot more work that needs doing and a lot more to prove that contention in bigger clinical trials and with further preclinical studies to examine the biology in more detail. So what I'll do now is to take our story forward another step and talk to you about some of the other oncology indications that we're exploring in order to try and test out this hypothesis further. And the first one of these is pancreatic cancer. I don't want to dwell too much on this slide, but suffice it to say that pancreatic cancer remains a largely unmet medical need. Although there are potentially curative treatments, surgery can be curative, in what overall is a very small percentage. That's probably more related to the fact that the disease is often discovered at a fairly advanced stage, at which surgery is no longer appropriate or even applicable, let alone likely to be successful. And the survival for patients who have metastatic disease is about 2 to 3 months. At the moment, drugs have a small impact on overall survival, maybe 2 or 3 months at best with some treatment. A large number of patients are not eligible for medical treatments that may have some survival benefits, such as multi-drug chemotherapy, because they're simply not fit enough to tolerate it, or the patients just don't want to go through that lengthy process of potential treatment when the benefits are uncertain. That's resulted in the fact that often in clinical trials and also in scenarios where patients don't want to undergo intensive therapy, where gemcitabine is used as monotherapy, the results are not spectacular. 1 year survival of around 18% overall and a mean survival, median survival of less than 6 months, patients on that therapy. So in terms of us taking our product forward, if we believe the hypothesis we have, which is that we are predominantly an anti-metastatic drug, then there is a logical rationale behind combining ATU-027 with a chemotherapeutic drug like gemcitabine, whose action is predominantly to kill cells in the primary tumour. In other words, a drug that's predominantly aimed at the primary. And in fact, as you can see here, we have preclinical data which kind of support that contention. So in this case, in one pancreatic cancer model, you can see that gemcitabine given on its own has a quite marked effect, at least in mice, on the primary tumour, but it has very little, if any, effect at all on metastases or metastases formation in this pancreas cancer model. ATU-027 has a comparatively weak effect, if any, on the primary tumour, but a very big effect on metastases. You put the two together and you get an effect on both the primary and on the metastases. Tumour burden's all well and good, but in addition, and very importantly, in two different pancreas cancer models here, you'll see that survival is improved by the combination beyond that of either drug used on its own, so either gemcitabine or 027 in both cases. So there seems to be, at least in mouse pancreas cancer models, a clear survival benefit associated with a benefit on tumour burden or tumour volume. So where have we now got to with taking that information into the clinic? Well, we've already completed a phase 1 lead-in or phase 1b safety study using the combination of gemcitabine and ATU-027. So that completed earlier this year. Because of the excellent safety demonstrated for ATU-027 in our first trial in monotherapy, we were given a comparatively easy ride by BfArM in Germany in terms of the regulators in Germany. Were allowed to do a 3-patient shortened safety cohort. This was in all comers. It wasn't specifically focused on pancreas cancer. The idea here was just to demonstrate that the combination of gemcitabine with our 027 was safe. Having confirmed safety, we've launched phase 2b in pancreatic cancer. It's first line in this indication, which is again important that we were allowed to go in as a first line therapy in this advanced indication. And these are patients who have either local, regionally advanced disease that it precludes surgical treatment, or they have metastatic disease already, which again precludes surgery. We have a 2-arm protocol here. The first arm here kind of mirrors the design of our monotherapy study for the 027, which is its twice weekly infusions over a 4-week period, in this case to coincide as far as possible with the standard 3 weekly infusions of gemcitabine, but we then have a gemcitabine only 1 month off period in which we can continue to look for safety signals and for any potential toxicity problems in what is now actually a real life scenario of a single cancer rather than the mixed group we had in our original trial. So again, safety is still one of the most important aspects of this study, but we're now also starting to look further at efficacy, and we have a second arm which you could call a low dose arm, in which we're only giving a single weekly infusion over 3 weeks. The rationale here you can see from the yellow gemcitabine bars, if you like, and the grey 027 bars, which is we're giving treatments to run together. So the idea here is that for patients, we have a matching regime of gemcitabine and ATU-027. Unlike in our original trial, we then move on in arm 2 to have a second monthly cycle of treatment. In arm 1, we have continuous treatment throughout. So we are able to compare these two different regimes for a variety of different endpoints. Now, unfortunately, I can't really share with you the results of the phase 2 trial, and we do have patients already randomised to this phase 2 trial across multiple centres in Germany, but we're going to have to wait for a pre-specified endpoint before we can start to talk about the results of phase 2. But we can say that phase 1b safety was concluded without problems. So again, just to have another sort of summary of where we are now, we know that ATU-027 is safe in monotherapy. We also have a suggestion that the agent is clinically efficacious. We now know that 027 is safe in combination treatment with standard chemotherapy, at least in this case gemcitabine, and we're looking at the effect of this combination in pancreatic cancer at the moment. The thing to bear in mind here is that there are still a lot of unanswered questions. And amongst these are that we still at this stage have not directly demonstrated efficacy against PKN3 in the endothelium of human patients. We have this data from our preclinical models, but as you can imagine, it's very difficult to get this data from man because it requires getting tissue, not just after treatment, but also you have to have a comparator before treatment. So it means that the patients have to undergo biopsies at least twice during treatment. This also requires studying tumours in which these biopsies may be, one, ethically acceptable, and also that the tumours themselves are accessible to that sort of technology. And it's not something we can do in pancreas cancer because of the risks of pancreatitis associated with taking blind biopsies, those tissues. It's just not done. So we have, and as Ali mentioned already now, signed up to run a preclinical, another clinical trial now, a phase 1b trial in head and neck cancer, and we're going to do this together with Professor Hisham Mahana, who's a very prominent UK head and neck cancer surgeon. He's the chair of the UK NCRI head and neck group. He's also chair of the research committee of the Council of Association of Head and Neck Oncologists. Now the idea here is this is going to be a dose escalation clinical trial, but this time in combination with what would be regarded by everybody as best current treatment for this condition. So you could argue that gemcitabine is not that for pancreatic cancer, but it was a step towards being able to run a combination trial with drugs that are regarded as being effective. In this case, 5-FU, or 5-fluorouracil, cisplatin, and cetuximab, plus or minus ATU-027. Now we're going to start off with a 1B safety trial in which we're actually going to open this up to other solid tumours in order to speed recruitment and to move through the phase 1B rapidly. The ultimate aim here, again using a 3+3 design, but this time at just 3 doses, would be to demonstrate that we have no adverse effect on these drugs which are known to be effective, and also to be, to have detailed PK measurements before going forward. But the rationale and the objective of this study has always been to move ultimately into a randomised controlled trial in head and neck squamous cell cancer. Now, in addition to being able to look at safety in this scenario, we're also able to do a lot more about looking at PD than we've been able to do in previous trials, because firstly we have accessibility of tissue, both potentially before and after from tumour, but also built into the protocol the sampling of normal blood vessels by taking muscle biopsies before and after treatment. Now that's important to prove out our intravasation-extravasation hypothesis, because it's one thing to look at the abnormal tumours in the abnormal blood vessels in the primary tumour itself, but it's also important to be able to demonstrate that we have an effect on other blood vessels in potential seed locations, and we regard that muscle biopsies here are a good surrogate for those blood vessels that we would never be allowed to biopsy in patients, i.e. lung and liver in this kind of context. So the endpoints, in addition to safety, tolerability and very detailed PK analysis, are going to include imaging endpoints with CT scans before and after treatment, very much standard, and analysis by RECIST. Biopsies, as I've already mentioned, in order to be able to look directly at changes in PKN3 at the messenger RNA and protein level. We can also look at changes in blood vessel phenotype and function, which is also important. We're also going to build in another potential surrogate or biomarker analysis here, which is to look at numbers of circulating tumour cells, which may be a marker for the fact that we're locking up the endothelium against cell extravasation, or intravasation rather. We're also going to try and isolate endothelial cells to see whether or not we can use them to measure PKN3 knockdown, something we want to do. But ultimately, if we successfully move through, as we're sure we will through the 1B study, we're going to run into a randomised controlled trial in head and neck cancer, which will be powered to actually look at clinical hard endpoints. So I think this is really the time for me to genuinely move on towards the end of our beginning and the last leg of our journey so far, which is to move away from oncology and towards a different indication and talk about ATU-111, which we are proposing as a pipeline in a drug. And I'd like to run you through the various different preclinical and clinical data that support that notion. So I'm not going to talk about the composition side of things. Jörg's already shown you that. I think it's just important to bear in mind that this DAC formulation in this context also contains a different targeted or different siRNA targeting, in this case, Ang2 or angiopoietin-2, which is an important angiogenic and vascular function protein. And in this case, our ultimate aim is to eradicate ALI. So that's acute lung injury. I don't want anyone to come away with the idea that we have anything but harmony in the ranks at Silence. And we're not developing drugs to get rid of ALI. So let me tell you a little bit about the villain of the piece here, which is Ang2, and a bit about the role that plays in human pathophysiology, before introducing what we do to this protein with ATU-111 and what the clinical consequences that might be. So there is a very extensive clinical literature implicating angiopoietin-2 as a biomarker for a number of human conditions associated with vascular leak. In particular, the condition that we've mentioned before, which is acute lung injury, also variously synonymous with adult respiratory distress syndrome and part of a big syndrome called multi-organ failure. And this is a syndrome that often happens to patients with severe sepsis after severe trauma. It may be associated with patients who've had shock. And we believe that angiopoietin-2 is not only a marker for this condition, but maybe a treatment target. So causality has been implied by both our own data and that in other labs. I think it's important to just emphasize actually what happens in acute lung injury at this point. So in acute lung injury, inflammation triggered by angiopoietin-2 and other chemicals results in effectively drowning in your own body fluids. So the lungs fill with fluid from your own circulation. It's important to bear in mind that this is very different to pulmonary edema as we see it in heart failure. So in heart failure, pulmonary edema is readily treated, at least in the early stages, by what we call diuretics. These are fluids that make you pee excess fluid out, or by drugs that dilate the blood vessels. And these are used in the clinic acutely, and they're also used in the chronic management of heart failure. Problem is, those drugs actually in pulmonary edema or fluid leak in the lung due to sepsis or to shock secondary to injury may actually aggravate the syndrome, because they may further compromise blood flow in the kidney and other important organs, and they may reduce blood pressure further. So for the pulmonary edema in ALI, ARDS at the moment, there are no effective medical treatments. Treatment comprises ventilation to try and drive fluid out of the lungs, and it still has a very high mortality rate. So you could regard this as being an unmet medical need. So angiopoietin-2, what does it do? Very briefly, angiopoietin-2 is able to inhibit the phosphorylation and therefore the activation of this receptor here called Tie2 and downstream signaling. In that context, it operates maybe as a kind of yin to angiopoietin-1's yang. One of them is anti-inflammatory, Ang2 is pro-inflammatory. So being pro-inflammatory, it does things to the endothelium that we've alluded to a little bit before when we were talking about PKN3. Ang2 inhibition can open up pores in the blood vessels, allowing chemicals and cells to get in and out of the tumour. So what happens with ATU-111? Well, as you can see here in what's called cecal puncture, which is an animal model of sepsis-induced acute lung injury. In this case, you make a small hole in the cecum. That's the bit in your large bowel that in man has an appendix dangling off it. If you induce a hole in here, you get fecal material and bacteria leak into the peritoneum of the mouse, inducing a slow burn sepsis, which can result in acute lung injury and other problems. Importantly, in this model, angiopoietin is a marker, if you like, of the sepsis consequences. As you can see here, cecal puncture induces this increase in angiopoietin-2 messenger RNA, and that's inhibited by about 50% by ATU-027. The consequence of inhibiting it are a change in phosphorylation of the downstream or the receptor system, indicating that this is there's actually a sequelae, if you like, in signalling as a result of knocking down Ang2. And why are we just not showing you a protein gel here? Because there isn't really a good antibody for Ang2 in rodent models at this present moment in time. So we're using activation of Tie2 here as a surrogate for showing that there's a change at the protein level. You know, messenger RNAs don't do functional things here. It's the proteins that they manufacture. So here, just moving on a bit, you can see that ATU-111 suppresses the expression of Ang2 gene in vivo in this different model. In this case, it's an LPS challenge. So LPS is a sort of endotoxin model. It's polysaccharide is very similar to bacterial cell wall protein. You administer this stuff, you trigger a septic shock type scenario, but it can be quite mild enough that LPS challenge can be used as a first-in-man scenario to test a drug. So in this case, you can see that LPS challenge results in an increase in Ang2 messenger RNA, which is prevented by treatment with ATU-111. Molecular changes, again, are all very interesting, but here you can see there's a direct clinical effect of 111 treatment in this model. As you can see here, 111 results in a leak of blue dye from the circulation into the lung. That's a marker for pulmonary edema. As you can see here, that's prevented with Ang2 siRNA in the DAC formulation. At the same time as changing pulmonary edema formation, in two different models, both the cecal puncture model and the LPS model, 111 treatment is associated with an improved activity score in animal models. And in the CLP model, where animals can actually die as a result of sepsis, there's an increased life expectancy and improved survival with treatment with 111. So to kind of round off finally, we believe that 111, by interfering with the production of Ang2, it can prevent pulmonary edema in models of acute lung injury and ARDS, and this is now a notion that we intend to take forward into the clinic. This is a route map for how we intend to do this. Maybe prior to this step, or very at the beginning of this step, will be a first-in-man study, which at the moment our best suggestion on discussion with many people is that this could be a volunteer study in patients who accept to have LPS challenge. We expect them to have an elevation in Ang2 levels, which we can at least get a go window for PD by pre-treatment with ATU-111. Of course, there's a long way to go before we do that. I could sort of briefly just allude to here the fact that, our ultimate goal will be to go into acute lung injury ARDS, but we have a lot of potential intermediate orphan indications, which are important indications in themselves, but may also be important go signals on the route to ALI ARDS. To kind of give some evidence for this notion that 111 could be a pipeline in a drug, these are a list of the potential indications for a vascular leak targeted treatment. The following here, in which Ang2 is an accepted biomarker, we've already talked about lung injury, ARDS, but also multi-organ failure, of which these two are one component. We have increasing evidence that patients who have heart-lung transplants, those who are going to get graft rejection, have elevated levels of Ang2, so it's not beyond the realms of possibility that this could be developed as an indication. There are numerous scenarios in which Ang2 is certainly a biomarker, even though we don't have evidence necessarily of it being causal. I think it's very clear, just want to be clear here that we're not necessarily aiming to develop clinical trials in all of those following indications, but it just kind of proves the contention that, potentially here with 111 we have a pipeline and a drug with numerous different indications we could target. And this is just really confirming why we want to target ARDS or ALI as our eventual goal here, because it's relatively common, it has a terrible prognosis, and there are no existing effective drugs for this condition. And our next steps, I think Jörg already alluded to that, are to do with CMC and taking these through tox studies. And eventually this process will lead to the initiation of our first-in-man trials. I don't want to sound overconfident, so I have delayed the order of this particular car. I think I rather like that number plate. And we'd like to conclude there, and thank you for bearing with us through what I know has been a very long journey, but let's say that we are now at least close to the end of our beginning. Thank you.